Good morning. Just want to acknowledge that we're speaking from Treaty 6 territory and the homeland of the Métis this morning. It's my great pleasure to introduce our honorary alumni lecturer, Dr. Don Wasylenki, a classmate of mine from 1971. Don and I actually grew up, I think, in Regina. I know I did. And we were, to my knowledge, maybe the only two coming out of Regina that year, at a time when there was no medical presence in the south of the province from the point of view of the College of Medicine teaching. And somehow we both made it out of Regina, and I'm still in Saskatoon, and he's in the big city of Toronto. How does that happen? I don't know. We spent our 4 years together, mostly without problems, but in what I would call a harbinger of things to come. Don initiated some interesting aspects to the college when he was a student. In his bio, you may have read, if you didn't, he started up a news report, a newsletter, or a magazine called Interface with one of his friends, I think from the class ahead of us, Dan Pollock. And it was really an interesting aspect of what he was able to achieve. I'm not sure he'll talk about it, maybe a little bit. The only other thing I remember about him is he had a Chevrolet convertible at one time. And I'm not sure what trouble that caused in medical years. Subsequently, in Toronto, he has been risen to the Department Head of Psychiatry of the University of Toronto. And he has received many accolades for his work, both scholarly and community associated, particularly in mental health and addiction areas. And he's also worked outside the country, I understand, and he may bring that up, I'm not sure, in his work that he created, I believe, and I'm sure helped to foster in a tremendous way in Ethiopia. Well, I believe this is the first honor from his actual alma mater, the University of Saskatchewan, that he's received amongst all the others. And I'm certainly very glad to introduce him, possibly from the first tee of the golf course. So without further ado, Don Wasylenki.
Hello. Can everyone hear me?
I can hear you. Sounds like it's working.
And you can see me okay?
Yes.
Okay. Well, first of all, thank you, Charlie, for that surprisingly kind introduction. You're definitely mellowed with age. And I'm impressed by the fact that you seem to be in your kitchen. So I take it you've even become more domestic as time has gone by. I'm not in Saskatoon, sadly. I'm in my basement in Toronto. Given my age and stage, I'm just trying to be very cautious about travel during this fourth wave. I want to thank the Alumni Association for inviting me to make this presentation today, and I'd like to thank everyone who's listening. I wanted to start just by acknowledging the fact that we have lost classmates since our last reunion. We also lost an outstanding former faculty member, Dr. Stuart Houston. Dr. Houston, as many of you know, was head of the Department of Radiology. He was a world-class ornithologist, and he and his wife apparently banded over 150,000 birds. And he was a very productive historian. He was a remarkable individual. So I thought we could just take a moment to remember our lost classmates and to remember Dr. Houston. Okay, well, my presentation is about the modern history of psychiatry in Canada. I hope this will be of broad interest. There have been some important developments in our field, which I think have had an impact on all of medicine. To start with, we need to remember that up until about 1960, most of psychiatry was practiced in government-run psychiatric hospitals. There were very few general hospital beds in Canada and few psychiatrists in private practice. The examples would be Essendale Hospital in Vancouver, Weyburn and North Battleford in Saskatchewan, Selkirk in Manitoba. There were 10 provincial psychiatric hospitals in Ontario, including 999 Queen Street. There was the Douglas Hospital in Montreal, Centracare in New Brunswick. These were very large institutions. They were basically set up to accommodate hundreds of patients. By about 1960, they were accommodating thousands of patients. They were overcrowded. They were understaffed, and there were very few effective methods of treatment. There was hydrotherapy, where patients were placed in bathtubs to calm them down. There was insulin coma therapy, where comas were induced to calm patients. There was unmodified electroshock therapy, which induced seizures. Patients had to be held down to prevent fractures. And there were even prefrontal lobotomies being done. These were scary places. There was a tremendous amount of stigma attached to them. Mothers would say to their children, behave yourself or you'll end up in Weyburn, or finish your vegetables or I'll send you to 999 Queen Street. There were movies, The Snake Pit in the United States, and later One Flew Over the Cuckoo's Nest. There was a report in the United States about state hospitals entitled The Shame of the States. There were studies done demonstrating the harmful effect of total institutional care, describing things like the social breakdown syndrome or institutional neuroses. So by about 1960, it was clear that something had to be done. And the solution was called deinstitutionalization. This was a process with two components. The first was the avoidance of care in total institutions for individuals with mental or physical disabilities. And the second was the concurrent expansion of supports and programs in the community. Now, deinstitutionalization became one of the most successful, in quotation marks, social movements of the late 20th century, because everyone was on board with it. If you were a conservative, you were in favor of deinstitutionalization because it promised significant cost savings. Provinces would no longer have to fund these large psychiatric hospitals. If you were a liberal, you liked deinstitutionalization because it was about freedom, liberating patients, and providing care in least restrictive settings. So it was a very popular process. Now, I'm going to talk first about how the process unfolded in the United States, and then I'll talk about how it unfolded in Canada, to just illustrate how two different approaches produce the same results. In the United States, during the 1950s, there was a congressional committee struggling with what to do about state hospitals. But in 1963, the Kennedy administration passed a very important piece of legislation, the Community Mental Health Centers Construction Act. Now, this was partly because the Kennedy family, John Kennedy's sister, suffered from a severe mental illness, schizophrenia, and the family had been aware of the shortcomings of state hospital care in Massachusetts. This piece of legislation said to states across the United States, if you will eliminate or significantly downsize your state hospitals, the federal government will create, fund, and operate a new class of facility, a community mental health center, to provide care for psychiatric patients in the community. Now, the goal of this initiative on the part of the federal government was to achieve a 50% reduction in the population of state hospitals across the country over a 20-year time frame. This was thought to be unrealistically optimistic. What happened, however, was the goal was exceeded. In 1960, there were about 550,000 Americans living in state hospitals in the United States. 15 years later, by 1975, it was down to about 190,000 patients. So a massive decanting of patients from state hospitals occurred. And there was a great deal of optimism and enthusiasm about this. This was the rise of what was called community psychiatry. The literature was full of reports about innovative approaches to discharging patients from state hospitals and closing beds and developing community support services. It was a very exciting time. But by the late 1970s, a concern began to develop. The General Accounting Office, which audits federal government programs in the United States, began talking about the failures of deinstitutionalization. And when they audited the Community Mental Health Centers program, they concluded that the centers were not fulfilling their mandate to provide community care for severely ill patients. And they identified three major problems. The first was that thousands of patients had been discharged from state hospitals before any community mental health centers had ever been built. The second was that even when community mental health centers were in place, there was no communication between state hospitals and community centers around the orderly discharge of patients. And the third and perhaps most significant problem was that these new community mental health centers discovered whole new patient populations, groups of people who had not previously been seen as needing psychiatric treatment were suddenly being targeted. And there was an emphasis on preventing mental illnesses, consulting to schools, a whole array of kind of social engineering approaches. And these centers became too busy doing this other stuff to provide aftercare for severely ill people who had been discharged from state hospitals. As a result, what was identified were many mentally ill people living in nursing homes with inadequate care in the United States. The prison population being expanded by many people suffering from severe mental illnesses. Homelessness and mental illness became a problem, and there was a rise in problems with addictions. The response to this in the United States was to develop model programs demonstrating that care in the community was in fact a reasonable alternative. So we had programs like Fountain House in New York City, Fairweather Lodges in Texas, the program for assertive community treatment in Wisconsin. But given the fragmentation and lack of coordination in the American healthcare system, these model programs were never applied to the population as a whole. So you had small pockets of excellence, but all of these other problems across large groups of the American population. So just to reiterate, the concept in the United States was to keep mental health separate from the rest of the healthcare system, but to situate it in these new community mental health centers. Now, the approach in Canada was different. In Canada, in 1963, a group of psychiatrists working under the aegis of the Canadian Mental Health Association produced a report called More for the Mind. And in this report, they argued that deinstitutionalization in Canada should be based on a philosophy of medical integration. That is, the integration of the care of mentally ill people into the general healthcare system. And this was to be done through the creation of general hospital psychiatric units. There were very few psychiatric beds in Canada at this time, and the vision was that we would create across the country in our general hospitals new units which could provide care right in our general hospitals for people with mental illnesses. Now, it was felt that this approach would reduce the stigma attached to mental illness, and also that it would make psychiatrists look more like real doctors by having them actually practicing in the general hospital. There was initial opposition to this idea. People said, we can't have these crazy people roaming around our general hospitals. They'll be frightening women giving birth in maternity wards. They'll be attacking surgeons while they're operating. They'll be disrupting all the functions of the general hospital. This was overcome. And what happened in Canada was quite similar to what happened in the United States. In Canada in 1960, there were roughly 50,000 Canadians living in provincial psychiatric hospitals. 15 years later, by 1975, this was down to about 15,000. So we closed 35,000 beds in provincial psychiatric hospitals across Canada, excuse me, and we replaced them with roughly 5,000 new beds in general hospital psychiatric units. Now, the idea was that these new psychiatric units would provide episodes of care, 2 to 3 to 4 weeks, for severely ill patients in acute distress, and that most of the ongoing care of these patients would be provided in the community. What happened here was very similar to what happened in the US. First of all, patients were discharged from our provincial hospitals before the general hospital psychiatric units had been established. Secondly, there was no communication between our provincial hospitals and our general hospitals around managing discharges. And thirdly, like the community mental health centers in the US, our general hospital units discovered new patient populations. So someone who was perhaps mildly anxious or mildly depressed could be admitted to one of these new units. These were beautiful new units with carpeting and draperies and nice furniture. They could have a little group therapy and some tranquilizer. Meprobamate was very popular at the time, and then be discharged back home. These general hospital units really didn't have much interest in admitting and providing care for severely ill people. They were told to go back to the provincial psychiatric hospital, which was significantly downsized and very, very poorly resourced. A psychiatrist named Barry Martin, who's a graduate of the University of Saskatchewan, did a study in the early 80s showing that the patient population in the general hospital psychiatric unit at the Toronto General Hospital was very, very different from the patient populations in the remaining psychiatric hospitals in Ontario. So we saw similar problems occurring. Mentally ill people in nursing homes, mentally ill people in prisons, homeless mentally ill people, and addictions. The response in Canada, because of course healthcare is a provincial responsibility, was for provinces to begin funding small community mental health programs to try and deal with these challenges. But the funding was grossly inadequate. For example, when the Lakeshore Psychiatric Hospital in Toronto closed, it had an operating budget of about $30 million. This was in the late 70s, early 80s. Of that $30 million that came back to the province, only $1 million was allocated to develop supports and programs in the hospital's catchment area. $29 million disappeared from the mental health system. And unfortunately, that was something that occurred across the country. So it's interesting to look at these two different approaches and how what they produced were very similar challenges. Now, faced with these challenges in Canada, we entered into a period in the 1980s and 90s of what could be described as mental health reform. What happened was that the provinces and territories began to develop a planning framework to address the challenge of creating a much more balanced mental health system in the country, balanced between institutional and community care, given this new model of care. Because when we did a study in Toronto, following up about 700 patients discharged into this new approach, we found that only 25% of patients 2 years later had not been readmitted to hospital or were doing well. And we found ourselves in agreement with an observation made by John Talbot in the United States that transferring the care from large psychiatric hospitals into multiple locations in the community had resulted in the loss of accountability for patient care. So the reform movement was an attempt to build supports and services and to build back in accountability. And there were reports done, mental health reform reports done in nearly every province. There was the Riverview Hospital Replacement Project report in British Columbia, the Southern Alberta study, the Graham report, the Putting People First reports in Ontario, the report on the downsizing of Centricare in New Brunswick. And all of these reports basically tried to move the province or territory towards a new framework for mental health care in Canada. And this framework had several important components. The first was the need to identify a target population for mental health services. And the target population identified consisted of individuals with severe and persistent mental illnesses, individuals with a diagnosable mental illness who had some chronicity and who were having difficulty functioning. This comprises about 3 to 5% of the population, and it became identified as the target for reorganizing mental health services. The second issue was the concept of the General Hospital Psychiatric Unit, and was this really a reasonable place to provide care for often severely disturbed and disturbing people? This was looked at very carefully. The conclusion was that yes, this was the correct way to integrate psychiatry into the rest of medicine, but that these units had to be very carefully constructed and organized. For example, there needed to be a separate area in the hospital's emergency department to deal with psychotic patients. There had to be an intensive care unit on the General Hospital Psychiatric Unit to manage disturbed and disturbing behavior. There had to be adequate bed numbers. There had to be adequate staffing. The unit had to have some relation to supports and services in the community so that adequate discharge planning could occur. And the unit had to have some relation to a regional resource for patients who required longer-term inpatient stays. And I'll come back to that issue in a minute. The third issue was, given that we are building a system with the General Hospital Psychiatric Unit as a core treatment facility and community supports and services for ongoing care, do we still need psychiatric hospitals? And during this debate, a very important paper was published in the New England Journal of Medicine by Miles Goodman and John Shore in Boston. And they said, look, in our jurisdiction, we have a good community mental health center, the Massachusetts Mental Health Center. We have adequate psychiatric inpatient beds in our general hospitals. We have community supports and services. But we still find that every year we need to refer a small group of patients back for longer-term regional inpatient care. The paper was called A New Class of Facilities for the Chronically Mentally Ill. And what they said was, this is not the old state hospital care that we're talking about. They identified 5 patient subpopulations needing longer-term inpatient care. And they talked about specific, highly intensive rehabilitation programs offered on a regional basis for these 5 patient subpopulations. And they said that you will require about 15 beds per 100,000 population, regional beds, in order to meet these needs. Now, this number, 15 beds per 100,000, became a touchstone across Canada as provinces were rebuilding and reforming their mental health systems. This became the number for what was called tertiary mental health care in Canada. So the idea was that primary care would be delivered in the community, secondary care, episodes of care in general hospital psychiatric units, and tertiary care would be delivered by highly specialized regional mental health programs in regional facilities. The fourth issue was, if we're going to be building supports and services in the community, what's going to be required? And this led to the realization that provincial psychiatric hospitals were providing a whole array of supports and services, not only psychiatric treatment. They were providing, of course, psychiatric treatment, but also medical and dental services, housing, vocational rehabilitation and workshops, opportunities for socialization, nutrition, exercise, a whole array of supports and services which now had to be provided in some sort of coordinated way in the community. And one of the real challenges as provinces began to address this issue was that in order to do this requires close collaboration between ministries, government ministries, programs and agencies on the ground. And this is one of the biggest challenges being faced by building these new reform systems. Because, for example, in Ontario, at one point, when the challenge had to do with housing for people with severe mental illnesses, the Ministry of Housing famously said, well, we're not in the mental health business. And the Ministry of Health famously said, we're not in the housing business. And so the issue became, how do we create the kind of housing needed by the target population? The next issue was continuity of care. Given that this new system is fragmented and that supports and services tend to function independently of one another, how does one create a coherent continuity of care plan that would allow a patient to move in an orderly way throughout this fragmented system? This gave rise to the concept of case management. Now, a case manager was a mental health professional, perhaps a nurse, social worker, or occupational therapist, whose job it was to see that patients on discharge from hospital receive the supports and services they need in the community. Initially, the idea was that the case manager would simply inform the patient of which programs he or she should contact after discharge. This didn't turn out to be very effective for large numbers of people who really had difficulty carrying out this kind of travel agent approach to case management. So it gave rise to the concept of clinical case management, where the case manager has a clinical relationship with the patient or client and carries out a number of essential functions. Assessment, assessing what the patient's needs are for community supports and services. Planning, developing a plan. Linking, actually linking the client to the necessary programs. Monitoring, ensuring the patient is doing well in those programs. And advocating on behalf of the patient. So this is called clinical or intensive case management, and is a core component of reformed mental health care in Canada. But still, there's a small group of patients who are what would be called treatment resistant and very disabled and chronically symptomatic. And this group of patients need an even more intensive form of community case management called assertive community treatment. And in this model, a team of case managers and psychiatrists take responsibility for the total care of a group of severely ill people, perhaps 100 clients at a time. And this team provides 24-hour a day, 7-day a week treatment, care, and support in the community. This is known as the hospital without walls model. There are roughly 40 randomized controlled trials across the world now showing the effectiveness of assertive community treatment in symptom management and overcome disability, and in avoiding hospital care for this very challenging patient population. The next issue in the framework is the issue of comorbidity, because it was recognized as the provinces developed their plans that many people with severe mental illnesses also have physical health problems. They have addictions, often they're frail and elderly. It may be young people moving from children's mental health services to adult systems, falling through the cracks. And again, this challenge of comorbidity meant that providers have to learn to work together more. And this has given rise to the concept of shared care in the mental health field, where mental health professionals work with professionals in other areas, perhaps developmental handicapped areas, another example, to provide care for patients. And where this has been most well developed is with psychiatrists working with groups of family physicians to share the psychiatric care and the medical care of severely disabled people. So that's shared care, an important component of mental health reform. The penultimate issue in the development of these frameworks was the issue of consumerism. Now, up until the reform movement, very little attention was paid to what patients or clients or consumers had to say about the mental health system. As mental health reform unfolded, these consumer voices became much more prevalent. And what decision makers heard from consumers was what we need are places to live, productive activities, and friends. What they were hearing from family members was, we need cures and better services. What they were hearing from professionals is, we need more services, we need more funding. But increasingly, decision makers began to support the consumer movement. Groups of consumers were provided with funds to actually develop self-help programs, and the concept of the peer support worker emerged. This was someone with a lived experience of mental illness who was provided with a job, with a position to advise professionals as to how treatment programs should be developed and how treatments should be provided to individuals. For example, on a general hospital psychiatric unit, there may be 1 or 2 peer support workers working closely with psychiatrists, nursing staff, and patients to make sure that the patient perspective is understood and respected. The last issue in building these frameworks was the issue of coordination. How to put all of this together, and in particular, how to create balance in a provincial mental health system, balance between institutional and community care. And the model looked at was the concept of a mental health authority. That is an administrative body that was responsible for all of mental health funding in a given jurisdiction. And it was thought that this would allow for a much more kind of needs-based approach to developing services and to allocating and reallocating resources. The idea of the mental health authority would be that it would consist of consumers, family members, professionals, and government, that it would control the entire budget for mental health in a given area. This model was tested in the United States in 8 cities, found to be highly effective in creating, as I say, a much more balanced system with community care and hospital care working closely together in a coordinated fashion. It created a great deal of optimism about what could be accomplished and a lot of innovation in terms of services and programs. So through the 1980s and 90s, this framework was evolving across the country as each province built its approach to mental health reform. In order to move this into the 21st century now, the government established a federal provincial advisory committee on mental health to try and assist the provinces in actually implementing the planning framework that had been developed. And the advisory body undertook what was called the Best Practices Project. And this project had two components. The first was a best practices literature review. A review was conducted of the world literature to identify evidence-based initiatives in relation to the framework developed during the mental health reform period. So once the literature review was completed, a national conference was held, and provinces were provided with information about what works, what is most evidence-based in relation to the issues in the framework. For example, provinces were reassured that the literature on assertive community treatment provided strong support for investing in that particular approach to care. The literature provided support for the idea that general hospital psychiatric units work best when they are embedded in crisis response systems in a given jurisdiction. The literature provided support for the idea that day hospitals can be an important component in structuring general hospital psychiatric unit care. The literature provided support for two particular approaches to vocational rehabilitation and housing called supported employment and supported housing. So at this conference, provinces were able to look at which direction some of these initiatives in their planning framework should pursue. The second part of the best practices project was a situational analysis. The provinces were asked to nominate what they considered to be exemplary programs which they had put into place. These programs were then vetted by an expert committee, site visits were made, and the very best programs were carefully analyzed in relation to how they were developed, how they were funded, and how they were being sustained, so that provinces could learn from one another about ways to move the framework, the mental health reform framework, forward. Let me give you a couple of examples. The Mental Health Commission of New Brunswick. What happened in New Brunswick was that a commission or mental health authority with an arm's length relation to government was established, headed by a very experienced civil servant, Eugene Niles, with a mandate to carefully manage the downsizing of Centracare Hospital in St. John's and to move resources to create a much more balanced hospital community mental health system in the province. This was extremely successful as the commission worked over 5 years in pursuit of its mandate and served as a model for other provinces, showing how putting all the resources together under the aegis of a single administrative body gives you a great deal more flexibility in terms of creating a more balanced approach to care. Second program was the Seven Oaks program in Victoria, British Columbia. In this program, small groups of patients being discharged from Riverview Hospital in Vancouver moved with staff into small residential units on Vancouver Island. And these units provided intensive treatment and rehabilitation in order to prepare people to move then onward into more independent, less supported living situations. So this is an example of how, if deinstitutionalization is done properly and carefully, it can in fact result in much better outcomes for patients. A third program in Ontario was a Consumer Survivor Development Initiative, where the Ministry of Health made about $4 million available to a group of consumers, people with lived experience of mental illness, former patients, to allow them to develop a number of supports and services in the community, small businesses, advisory groups to mental health professionals, and to fund peer support workers. This program was carefully evaluated, and it was shown that the several hundred consumers who participated in the program showed marked decreases in their use of formal mental health services, particularly general hospital psychiatric unit emergency services and inpatient care. So this whole best practices project provided a lot of support in order to try and move these frameworks for mental health reform forward at the provincial level. Now, I'll finish up by talking about another very important recent development in terms of moving things in the direction of more balance. There is now in Canada a body called the Mental Health Commission of Canada. Again, this is a body with an arm's length relationship to government, charged with carrying out programs and projects to improve mental health in the country. Two of the foci of the Mental Health Commission have been developing projects to reduce stigma in relation to mental illness and tackling the problem of mental illness and homelessness. Now, I'm not going to say too much about the stigma reduction projects. There are a number of them. They've been very effective. This is the idea of overcoming the NIMBY idea, yes, I'm in favor of psychiatric services in the community, but not in my backyard. I'm in favor of housing for people, but not in my backyard. And I think it's fair to say that the main finding from many of these projects is the best way to remedy stigma is to give people the opportunity to have actual contact with people who do suffer from a mental illness. Tends to reduce all the fears and fantasies that people have about these individuals. But the homeless project has been extremely exciting. Studies have shown that up to about 30% of people in homeless populations in North America suffer from mental health and/or addiction problems. And before the project launched by the Mental Health Commission, the approach to this problem was to identify someone who is homeless with a mental disorder, to work to try and engage that person while they're living in a shelter or on the streets, to then attempt to move on to developing a treatment program for that person, still while they're living in a shelter or on the streets. And only after they are fully engaged, treated, and stabilized does attention then turn to finding a place for that patient to live. And often the search is for some sort of supported housing or a group home kind of setting, which in most jurisdictions is very difficult to find. Now, the approach launched by the Mental Health Commission of Canada turns that whole process around. It's called Housing First, Homes First. It's a model developed in New York. And what it says is that when you encounter someone who is mentally ill and homeless, the first thing you do is find them a place to live immediately. And once they are situated in a place, you provide them with the amount of support necessary to keep them there. And that is usually an intensive case management program or an assertive community treatment team. And only once you have a person housed off the streets, out of the shelters, and supported, do you then begin to build a treatment program. So homes first. The federal government allocated $110 million to support a randomized controlled trial of this homes first approach across the country. By the way, in French it says chez soi. The program was implemented in Vancouver, in Winnipeg, in Toronto and Montreal, and in Moncton. And in each of these cities, the Homes First program was compared to usual care for severely ill people. It was modified somewhat to meet the specific needs of different cities. So in Vancouver, for example, the program placed a little more emphasis on addictions. In Winnipeg, there was a little more emphasis on Aboriginal issues. In Toronto, on multiculturalism. In Montreal, on the French context. And in Moncton, how the program might function in a smaller city. The 2-year follow-up of this program has been extremely gratifying. People who are housed continue to be housed, functioning better and doing better in terms of their mental illnesses. Canada now has a reputation in the world as a result of this program in this whole field of mental illness and homelessness. And I just heard recently that one of the Scandinavian countries, I think it was Norway, has decided to embark on a national Homes First initiative to deal with homelessness and mental illness in the way that we've dealt with it here in Canada. The challenge now, of course, is to sustain this program, to sustain the funding. So in conclusion, what does all this mean? It means that we basically know what we have to do to deal with the challenges of deinstitutionalization. We've developed a framework for dealing with it. We've looked at evidence in support of the framework. We've carried out a very important initiative in relation to homelessness and mental illness. What is required now is, first of all, more resource. The feeling is that in order to create and sustain a balanced mental health system in any jurisdiction requires about 11% of healthcare funding going into the mental health and addictions area. In Canada, we're down at about 7%. So we need a significant infusion of funds in order to make this kind of balanced mental health system a reality. Secondly, we need administrative models so that the funds that are allocated properly in relation to carefully defined priorities. And finally, we need political will. And it's, I guess, somewhat gratifying to hear now that we're in an election period, all of the political parties talking about more funding for mental health and addictions. Hopefully that funding will be forthcoming and will be properly applied. So I'm going to stop there and leave some time for questions and discussion. I hope you found this presentation at least interesting. Thank you.
Don, thank you. That's a wonderful, very comprehensive outline of what's happened over the last almost century. Eloquent. Let me tell our participants that they can put any questions in the chat section. If you click on chat, it's at the bottom of my screen. I or Derek would pick up your questions. I'm not sure Derek has found any questions yet. If not, I will, at the moment, ask one thing. Don, many of our participants are family physicians, and I know you brought that up as part of the sharing care with psychiatrists, and probably with the other model supports in the system. But what do you feel is the level of care that a family physician in general can continue with a patient? How far along can they provide care more or less as a family physician and not have to refer out to further programming?
Well, I think the answer to that question, Charlie, the answer to that question is it depends. You know, if you're a family physician who has access to a psychiatrist in a shared care model of treatment, where the psychiatrist comes and meets with you on a regular basis, discusses the patients that you're looking after, and talks to you about how you're handling the medications and what other supports and services are available to the patient, then I think a great deal of care can be provided by family physicians. If, on the other hand, you're a family physician working by yourself, having a lot of trouble even making a referral to a psychiatrist, not having access to psychologists or social workers or occupational therapists in the community, it becomes extremely difficult. And in that case, your best approach is to try and, I think, refer the patient to a mental health program. But I think we should be pursuing the shared care model because it has great potential for enhancing the ability of family physicians to treat people with mental illness. And also, the shared care model also multiplies the,
No, carry on.
It multiplies the effectiveness of the psychiatrist because instead of treating individual patients, the psychiatrist is interacting with a number of primary care physicians, all of whom are treating more individual patients. So it has a multiplier effect in terms of making mental health expertise more available. This is a model, by the way, that was in the early days developed in Saskatchewan by Griff McCarricker and his group at University Hospital. When the psychiatrists traveled to a small community, I forget which one it was, near Saskatoon, on a regular basis to meet with groups of family physicians. It was one of the first examples in Canada of shared care before we even knew that shared care was a concept. Saskatchewan was a leader in many ways in the early days of community psychiatry, and Griff McCarricker was a real pioneer in North America in developing this whole field. He had maybe of interest to people to know that even though the direction in Canada was to move from psych hospitals to general hospital units, Griff McCarricker had developed something called the Saskatchewan Plan. And the Saskatchewan Plan was for a number of small regional psychiatric units to be established freestanding, not necessarily in general hospitals. And the first one was built in Yorkton. And what was interesting about that was that the architect who designed the York facility decided that he should experience psychosis in order to know what kind of architectural unit should be developed. So he took LSD, and he realized while he was on his trip that he wanted to be close to the ground, that he didn't want to see any long corridors, and that he wanted to see a lot of greenery. So this unit, which was built back in the 70s, I think, there were no long corridors. Everything was circular. All the furniture was much closer to the ground, and there were plants everywhere. I'm sure that unit is still existing, but it was said to be very, very unique at the time that it was built.
Yes, you're right. I certainly remember part of the Saskatchewan model in that being training in obstetrics and gynecology on the 4th floor of the University Hospital. By that time, we had the psychiatry unit in the hospital on the 5th floor. There was some controversy in that situation as to patients being close by. But for the most part, it worked. There was only a few instances where there was difficulty. I do have a question on our chat here. There was a question about neurology and psychiatry being closely allied in the past. Do you see any links evolving again between neurology and psychiatry as the approach to mental illness?
Well, there's a particular there's a whole field of psychiatry evolving now called interventional psychiatry. And in this area, psychiatry has moved from electroconvulsive therapy, which is still, by the way, very effective for the treatment of severe depression, to something called transcranial magnetic stimulation, which is induction of an electrical current by a magnetic field, which is much more focused and specific, doesn't involve the induction of a seizure, but is shown to be quite effective in treating treatment-resistant depression and PTSD. Most dramatically is also being developed is the whole area of deep brain stimulation. Now, this is an effective treatment for movement disorders in neurology and neurosurgery. But Helen Mayberg and her group, originally in Toronto and now in Emory in Atlanta, have identified an area in the cingulate gyrus which seems to be important in depression. And so now neurosurgeons are able to implant electrodes in that area, provide patients with severe treatment-resistant depression with a stimulator, and they can in fact then have a stimulating current into the cingulate gyrus, which over a period of months to perhaps a year does seem to be very promising in terms of treating people who have not responded to medications and not responded to ECT, have not responded to rTMS. So this is deep brain stimulation. It's very experimental. It's used only for people who are severely treatment resistant, but it does show some promise. So in this area of interventional psychiatry, psychiatry and neurology may be coming back together again after having been apart, I think, for a considerable period of time. The other area that people have likely heard about that's developing in psychiatry is what's called psychedelic psychiatry. Now, back in the 60s, there was a little bit of experimentation with LSD as a possible treatment for alcoholism. Some of this work was carried out in Saskatoon by Ian MacDonald and Frank Coburn at the time. But it's re-emerging now, and there are two substances that are of particular interest. One is psilocybin, which comes from mushrooms, and it's now been manufactured. And one of the approaches is called psilocybin-assisted psychotherapy. The idea is that by taking a hallucinogenic compound like psilocybin, person's defenses tend to be dissolved, and person may gain access to conflicts and traumas that they've defended against and which ordinarily might require years of psychotherapy to uncover. So the idea is that you work with a therapist while you're on your psilocybin trip, and that subsequently the work with the therapist picks up on some of the themes that emerged. The other use of psilocybin has been in micro amounts for the treatment of depression, again, 2 or 3 times a week. Microtherapy with psilocybin has been shown in a couple of trials to be as effective as the antidepressants that we have. The other substance that I'm sure you've heard about is ketamine. Ketamine is an anesthetic agent and a party drug, which is shown to be particularly effective in treatment-resistant depression with suicidal ideation. It's given by infusions. Patients who are severely depressed and acutely suicidal can have a ketamine infusion, perhaps twice a week for a period of about 3 weeks. Seems to have a very significant impact on the depression and on the suicidality. There's also a type of ketamine, S-ketamine, which is being developed as a nasal spray as a treatment for treatment-resistant depression as well. This is all very early stuff, but there are, as you may know, ketamine clinics springing up all over Canada now to provide infusions. Very expensive, costs about $3,000 for one infusion period of 2 to 3 weeks, but dramatically effective in some cases. So psychedelic psychiatry and interventional psychiatry are two areas that are currently being carefully developed.
Well, thank you. I think that answers a bit of questioning from a few other people, but I think we should put a rider on your responses to say maybe don't try this at home at the moment, especially the deep brain stimulation. But very interesting that you brought us up to date for what is in the experimental clinical trial field. Excellent. Maybe one quick last question before I'm supposed to end the session is a question about homelessness. What type of patients are most commonly found or not in the chronic homelessness situation? Is it a psychosis type of problem like schizophrenia more commonly? Is it a depression problem? Is it a substance abuse problem?
All of the above. All of the above. Many people with schizophrenia do become homeless. Many people with treatment-resistant depression become homeless, and many people with addictions become homeless. And I think probably the most common situation is comorbidity, where you have people with severe depression, post-traumatic stress disorder, who self-medicate with substances, so that when we encounter them, they're suffering both from the severe mental illness and from the addiction that has resulted from them trying to treat themselves with cocaine or other substances. So they're complex problems. There's also a lot of physical illness in that population. And that's why we really have been searching for the right approach. And I think the Homes First approach is a very, we should be very optimistic about it.
Well, thank you very much. And unless Derek intervenes, I'm going to say that that was a wonderful presentation, and we really appreciate your lectureship here.